Thank you so much, Wendy. And thank you to everybody who is here today for some great conversation that we've had this morning and this afternoon. Thank you again for inviting me to present to this important policy forum on how the Commission on Cancer Standard has established a framework for the development of navigation services to cancer patients across the country. I'm certainly honored to be here. The Commission on Cancer, just a little bit about us, a consortium of professional organizations. We're dedicated to improving survival and quality of life for cancer patients, primarily through standard setting. The Commission recognizes approximately 1,500 cancer care programs across the U.S. that voluntarily hold their programs accountable to meeting established standards that are designed to support cancer programs' delivery of comprehensive, high-quality, multidisciplinary, evidence-based, and patient-centered care. The Cancer Department of the American College of Surgeons also houses a national cancer database that's used to analyze and track patients, their treatments, and outcomes. And that data represents approximately 70% of all newly diagnosed cancer cases nationwide and has more than 34 million historical records. So beginning in 2009 and released for implementation in 2015, which we've heard mentioned several times this morning, the Commission on Cancer established this patient navigation process standard, requiring all accredited programs to complete a triennial community needs assessment and develop a process for navigating patients. I think most of you in the room are familiar with the standard language. So why was it established? And I think that this is probably, at least in my opinion, the most important slide that I'll present to you today. I think it was established for all of these reasons, so if you'll bear with me, I think I will go through these one by one. So first of all, to increase awareness of the social determinants of health impacting persons in the program's catchment area. Secondly, to really encourage programs or to mandate that programs identify the at-risk for cancer population and turn the focus to one of health equity, an important component of patient navigation as a concept. Identifying resources that help patients overcome access barriers, and then, and possibly more importantly than looking at the resources available, is identification of resource gaps. And then encouraging development of collaborative efforts with community partners to address those gaps, facilitating a process for programs to reach out directly to providers, systems, and our patients to determine barriers, and then finally providing the process framework for delivery of service to those most in need. The community needs assessment drives programs to look inside their community to the cancer incidence and mortality data, to surveillance data, to population statistics such as gender, age, disability, and identification of other vulnerable populations, to behaviors such as obesity and smoking rates, social challenges related to transportation, lodging, poverty, educational attainment, and insurance status. One of the things that we see when we look at community needs assessments that are provided to us as compliance information for this standard is that programs aren't necessarily looking at it from an oncology-related perspective, and we do mandate that that happens. So that's an important piece of the puzzle, that we need to look at all those things that impact our populations in our communities. The assessment must then identify resources that exist in the community, as I mentioned, and address the challenges identified by the assessment and the gaps in resources that are discovered. The cancer program completing the assessment should make plans to address those gaps as the healthcare system. Also critical to the successful process is the engagement of community partners and or coalitions in this work, and resources should be made available to the patients who perhaps are independently able to access them, and then used as tools for staff navigating patients who might otherwise not be able to access those services or be aware of the programs and services available, as we've heard from several of the best practices that have been presented to you earlier today. So I just think this is a really nice schematic that talks a little bit about the how that that a piece of this may be done. So to ensure that barriers are identified by those who are experiencing them, I think it's important for once the program has analyzed the oncology-related data and identified resources, the first two pieces of the puzzle, that the program then implements methods such as these listed here to ensure that the identification of barriers to care includes those that are expressed by patients and the community, especially the at-risk community. So public forums, listening sessions, focus groups, interviews, and surveys are important considerations, and this schematic that I present here provides the user with guidance on what methodology may be most appropriate for various segments of the population. It's not the only piece of the community needs assessment puzzle, but certainly a critical one. So we've heard a lot about barriers today, and it's interesting that the framework is so solidly encased in these identification of barriers in these three buckets, but that's certainly how this patient navigation process standard is written by the Commission on Cancer as well. So to determine the potential to reduce cancer disparities, these barriers must be identified in these buckets and addressed in the navigation process outlined by the Accredited Cancer Program. So patient-centered barriers identified by methods just discussed in my previous slide might include things like cost or insurance coverage, language or literacy, social support. We're hearing a repeated theme today. Possibly competing priorities or challenges experienced by the patient, transportation, child care, housing, or family care. Other patient barriers may include, of course, comorbidities or disability, and then fears and perceptions may keep people from seeking care, as everyone in this room is well aware. Provider barriers such as time constraints, communication, workforce shortages, or attitudes create barriers, and reimbursement and mandated physician quality metrics can create barriers for providers. Others may be created by the health system itself, including things like fragmentation of the system, lack of a shared EMR, hours of operation that do not cater to the needs of the community, the physical environment itself, or perhaps the location of the hospital or the clinic. So resources and resource development, as a part of the Commission on Cancer standards, we also require that programs identify their resources in several of the buckets that are listed here on this slide. Once the assessment is completed and the barriers have been identified, the programs are asked to prioritize and address specific identified barriers. So a comprehensive inventory of internal and external resources is an essential component of the standard. All patients and caregivers who are able to access resources independently should be given information about those programs and services that are available. And the facility must, as part of their navigation process, address how the at-risk patient will be assisted with accessing programs and services to address the barriers that might keep them from being able to follow through with care or treatment of their disease. Most often, this is achieved by having designated staff work with patients, whether he or she is a navigator, a social worker, a nurse, or an other provider. As noted, the Commission on Cancer does not require that there is a patient navigator, but rather a patient navigation process. The list of standards above indicates which categories require resources to be identified. In eligibility requirement 10, the Commission requires programs have psychosocial services to address physical, psychological, social, spiritual, and financial needs as a matter of program eligibility prior to seeking accreditation. In eligibility requirement 11, lymphedema programs, pain management, programs to address those patients with physical impairments and disabilities, lifestyle and weight management programs, physical and exercise therapy, reflexology, massage, chiropractic care, occupational therapy. In eligibility requirement 12, we look at nutrition services and ask that programs identify nutrition screening, comprehensive nutrition assessment, nutrition counseling and education. And in standard 2.3, programs must have genetic counseling and risk assessment services available, and in standard 2.4, palliative care services. So those are some of the categories of resources that we're actually mandating that our accredited programs have. There are certainly other categories of resources that anyone who is in the work of navigating patients are well aware of. In addition to the patient navigation process standard, we have a distress screening standard and a survivorship care plan standard, both released for implementation in 2015 as well. Distress screening, establishing that all patients be screened for example, anxiety or depression, and referred for comprehensive psychosocial assessment and development of an intervention plan if screened positive. I guess one could term that development of an intervention plan patient navigation, actually. Resources to meet sometimes very complex biological, psychological, social needs of patients need to be identified through that whole distress screening process, and if gaps exist, addressed by the program. Certainly, evidence is building, as we've heard earlier today, that indicates that positive patient outcomes across the cancer continuum when distress of any etiology is addressed, patients in need are navigated, patients at risk are navigated, and survivors are empowered with information and given recommendations for a course of future care and resuming a well life. These are the three kind of buckets that I think of being generated out of our standard for accreditation. Although it may be critical to identify somebody to perform the role of navigator and navigating patients for those at risk, there are various tasks that can fall within the boundaries of navigation, and it is important that those roles are well defined and it is determined who will fulfill them. The navigation process includes these three things: the use of community needs assessment as a building block for program development, implementation, and evaluation, developing then strategies to address those barriers and resource gaps to improve outcomes, and then finally identifying how patients will be navigated. So required documentation for compliance with standard 3.1. Each calendar year, the program must upload a copy of the results and findings of their triennial community needs assessment and documentation of how they're monitoring, evaluating, and the findings of their navigation process, including the health disparity populations that they've identified and the barriers that they are addressing. The metrics that we are looking at are listed here. Conducting that needs assessment once during the 3-year accreditation cycle to address barriers and or to identify disparities and barriers to care, to establish that navigation process and identify resources to address barriers that are provided either within the system or within the community. Each calendar year, the barriers to care are identified and assessed, and the navigation process is reported to the Cancer Committee. And then each calendar year, the process is modified or enhanced to address ongoing or changing needs within that system. So just a little bit of data that I was able to pull from one survey year. So this is about 1/3 of our cancer programs that were surveyed actually in 2017. These are the health disparities populations that they decided to focus on. And as you can see, most of our accredited programs are focusing on the patient disparities population of those who are socioeconomically disadvantaged. Also, a large portion of our programs are focusing on geography, and I think that has to do with our true commitment to accrediting programs that provide care near you. So many of our programs are smaller programs in rural areas. Other population of disparities that are identified are listed here: age, immigrants and refugees, gender, disability, veterans, etc. So the barrier care categories that are being focused on, this was 459 programs that choose to address specific barriers in these categories. As you can see, most programs are choosing to address barriers that are patient-centered barriers. There are, however, 8 programs that are looking at the health systems barrier as their barrier of focus, and 6% that are looking at provider-centered barriers. So of the 38 programs identifying a health system barrier, this breakdown shows that a fragmented system was most often identified as the significant barrier, and of the 27 programs identifying a provider barrier, this breakdown shows that workplace shortages were a significant challenge. Patient-centered barriers were identified for 394 out of the 459 programs. And as we see in the literature and hear from patients, cost and insurance coverage and transportation are the greatest challenges faced by patients and the areas of focus for the Commission on Cancer accredited programs. I think that there's just a few, as I think about this, future considerations. These are sort of made up in my mind, so certainly not something that is in the works of happening, but certainly things that I think we need to consider. I think that we need to continue to develop technical assistance kinds of resources to assist programs with completing their community needs assessment, because it's such a critical piece of starting this whole process. I think that advocating for navigation service reimbursement and inclusion in a bundled payment when evidence indicates that service is needed is an important consideration, and it's not the first time we've heard that today. Outlining or the licensing or certification requirements for staff navigating patients and defining eligible navigation providers is kind of an ongoing and maybe in process task that's happening right now. I think, to Ron's earlier point, defining and tracking quality metrics and outcomes, possibly one of the more important things that we can do right now. And then I think that there's potential in the future for us to consider as an accrediting body that navigation service provision in some program categories may need to become a requirement. I think that we're not anywhere near headed in that direction, but I think that's a possible future consideration. So in conclusion, I think that through formalizing the navigation process and setting a standard requiring programs to know their community, to analyze their cancer-related data, to define their at-risk populations in their service area, to understand their patient, provider, and system barriers, and work to eliminate them, that we expect to see positive impact on patient-related outcomes and progress toward the elimination of cancer disparities in systems across the country. And I just leave you with a couple of resources. Both our program standards manual, the program standards manual that prescribes navigation services in our breast centers, as well as a new a resource that we helped the GW Cancer Institute to create that provides a roadmap to how to do a community needs assessment and be in compliance with our standard. So again, thank you very much for the invitation to join this forum. I look forward to the rest of our panel presentations today.